So I think the implementation of CDK4/6 inhibitors in clinical practice has really revolutionized the way we treat the most common subtype of breast cancer, that is hormone receptor positive, HER2 negative breast cancer. And in the past, we've had one agent, Abemaciclib, that was approved for patients with a very high-risk disease, meaning with 4 or more nodes or 1 to 3 positive lymph nodes and additional risk features. Now we have a second agent, Ribociclib, that received a broader approval that encompasses this very high-risk population, but also patients with any node-positive disease or even node-negative with biologically high-risk disease, like grade 3 or selected based on genomic risk. And I really think this is able to address a large population of patients, about 1/3 of all the patients with hormone receptor positive early stage disease, and patients that have a relevant risk of recurrence. And so right now, having both Abemaciclib but also Ribociclib as approved agent, and in particular Ribociclib also for patients with certain node-negative breast cancers or node-positive with lower genomic risk, I think it's a great option, it's a great opportunity to have in clinical practice, and it allows us to tailor better our treatments, including in those patients with very high risk, because now we can really offer treatments with different toxicity profiles and adapt them based on the comorbidities and preferences of the patients. I feel since we started observing the results of the Adjuvant CDK4/6 inhibitor trial, there has been one major question in all of our mind. And the question is, are we curing or are we delaying recurrence, and are the patients remain recurrence-free once you discontinue the Adjuvant CDK4/6 inhibitor? And with Palbociclib, for instance, we saw in a specific trial, Penelope B, that after discontinuation of Adjuvant Palbociclib, patients started to recur more frequently. And so everybody's been wondering what will happen with Abemaciclib and Ribociclib, and gladly, in both the monarchE trial with Abema and the NATALEE trial with Ribo, we didn't see this increased risk of recurrence after discontinuation of the CDK4/6 inhibitors. Actually, we saw the opposite, that in patients with 100% of the patients off the Adjuvant CDK4/6 inhibitor, with a long follow-up, we've seen that the benefit between the control arm and the CDK4/6 inhibitor adjuvant arm has been widening. And so I think the latest update that led to the approval of adjuvant Ribociclib basically confirmed this. With all of the patients off adjuvant Ribociclib, we have seen a deepening of the benefit. We've seen a 5% IDFS delta, and we've seen basically what we had already seen also with Abemaciclib, that these agents hopefully are curing, are basically eliminating micrometastatic disease. And so I do think that looking at this data evolve will be very important. We want to see 5-year results, 6, 7-year results, and even longer term results, because this patient keeps recurring. We know that this disease keeps recurring even in decades, but I do think that the current data is available is extremely promising. So in truth, I think that when you start slicing the population of a trial, the statistical assumptions become complex, and it's hard to find always a statistical significance in all of the subgroups. And even if we're talking of NATALEE, a 5,000 patient trial, when you start looking at the specific stages, there is a chance, of course, that the hazard ratios change in all this population, that the confidence intervals cross 1. But I think what we really care about is that all of the hazard ratios trend in the right direction, do not go beyond 1. And this is basically what we've seen in all of this population. In truth, Ribo seems to provide a benefit. And although the hazard ratio can trend between 0.6, 0.7, 0.8, I feel that in general, our perception is that in most of the population that were enrolled in NATALEE, there seems to be an approximate 25 to 30 to 35% reduction in the risk of recurrence, and this supports the use of the drug in this population that was enrolled, and there really was no subset of patients that we can recognize that did not derive a benefit from the drug. Still, I think we need to look deeper, and we have to develop biomarkers to identify those patients deriving the most benefit from this drug and those patients instead not deriving benefit, so that in the future we can better tailor these drugs and only offer them to the patients that benefit the most from them. But for the time being, with the data that we have, I think there is really most of the population, most of the subsets includes in the NATALEE trial, as much as in the monarchE trial, seem to benefit from adjuvant CDK4/6 inhibition. So I think that the toxicity profile observed in NATALEE was very favorable. And one of the reasons why is that the trial included a lower dose of ribociclib compared to the metastatic trials. And we know that this leads to reduction in certain types of toxicity, including neutropenia, fatigue, and many other types of side effects. One that was not too different is hepatic toxicity, LFT increase, that is still there, but is observed in about a quarter of the population. Most of the patients do not have this, and it's mostly a laboratory abnormality that doesn't impact on patients' quality of life. And then when you look instead at QTc interval elevations, they were quite infrequent, observed in 5% of the patients. So overall, I would say that ribo seemed to be very well tolerated in this trial. And especially looking at side effects that impact on patients' perception and quality of life, it seemed like from the trial perspective, there wasn't many of these toxicities. One thing that is important is that the tolerability that patients have for side effects is different in the early setting compared to metastatic setting. We see this with aromatase inhibitors, that patients that are on AI or CDK4/6 inhibitors tend to tolerate side effects better in the metastatic setting when you're basically treating a metastatic disease compared to when there is no disease observed and you're giving an adjuvant treatment. But with that said, the rates of discontinuations were fairly low in the adjuvant CDK4/6 inhibitor trial. Most of the patients were able to remain on the CDK along the trial, and so I do feel that overall we can say that ribo was well tolerated in NATALEE. So I was extremely excited to present at San Antonio at this symposium this real-world analysis we conducted. And we basically looked at 7,500 patients in the Flatiron database that have hormone receptor positive early breast cancer that have received surgery and started adjuvant endocrine treatment. And our idea was, like, first of all, characterizing the population, understanding how many of these patients would be eligible for adjuvant Abema or ribo based on the clinical trials criteria, and what are the outcomes for these patients at 5 years. And what we found is that approximately 15% of the patients in the real world seem to be eligible for Abemaciclib based on the monarchE criteria, and about 30%, actually 33% of the patients would be eligible for adjuvant ribociclib according to the NATALEE criteria, so approximately double the population. And when you look at outcomes in this population, you will see that 20% of the patients eligible for ribo and 30% of the patients eligible for Abema are expected to experience a recurrence within 5 years. And so these are early recurrences. We expect that this picture is even worse when you look at 10-year outcomes, 15-year outcomes. And so I think this reinforces the unmet need. This reminds us that when we're looking at these patients with node positive, hormone receptor positive disease, or node negative with high biologic risk, these patients do recur, and do recur also early. 20 to 30% of these patients have one recurrence within 5 years, and so we do need strategies to mitigate this risk of recurrence, and CDK4/6 inhibitors in the adjuvant setting are among the tools that are helping us to reduce this risk of recurrence. And we should always remember this when we see a patient in the clinic, that we have to utilize all the tools that we have available in order to optimize outcomes for these patients.